Hello, my name is Paul Travatt. I'm the Macmillan Nurse Director for the North East London Cancer Network, and I'm here today to talk about the Prostate Community Health Clinic in Newham. I think what's really important if we're going to be involved in any innovative practice is spread. We need to communicate the ideas to a wider audience. The NHS, in fact, many companies are very good at doing great little projects really well, but they forget to share them, so that what tends to happen in 2 or 3 years, somebody comes along and says, here's an idea, we need to do this. So today it should be all about communicating the vision, communicating the idea, and projecting that to a larger audience who then can duplicate it. And what I wanted to try and do with my talk today was show them where we went wrong, so that they can actually work harder and smarter. What we've been trying to do through a variety of different formats is profile the work of the clinic. The clinic sadly came to an end around 12 months ago. So what we've been doing is wrapping up the evaluation and all the research and the findings and the data, sharing that with both a cancer audience and a general audience. We've been working closely with both the National Cancer Action Team, Prostate Cancer UK, to see is this idea transmittable to a wider audience? Can we take the clinic that was in North East London and actually take it to another area? And at the moment there are conversations going on about that. The other idea is to profile it, and we were very lucky to have a drop-in the Improving Outcomes Cancer Strategy 2-year plan that recognised the Newham prostate as an area of best practice and one that should be shared with other audiences. So what we've been really doing is just looking at how we communicate what we've been doing already. So the purpose of my presentation is not rocket science. I'm going to take you through why we did what we did, how we did it work, if it did work, other things that we can share with you, because really what I want to put over to you today is for you to take away from this that if you're interested in this sort of pilot, how you can work smarter than we did and you don't have to work so hard. So my learning becomes in some ways your learning. But why we did it is pretty straightforward. We know prostate cancer is a pretty nasty disease. It affects around 41,000 men are diagnosed with it in a year. There are around a quarter of a million men living with the disease. We know it's associated with age, so we're going to see an awful lot more. And more recently, certainly within the last 5 to 10 years, there's been a greater spread of the use of PSA testing, so we're starting to see prostate cancer coming up the league table as a fast-rising cancer. We know it's the second most common cause of cancer death in the UK in men after lung cancer. And around just over 10,000, just under 11,000 men die every year. Now, the more specifics around prostate cancer that we're going to talk about in this pilot is that in black men, it tends to be 2 to 3 more times more common and diagnosed. So that's the particular issue we're going to be talking about. What we also do know from the research that we've done previously is that there is a lower awareness in B&E communities of the signs and the symptoms, and men are just not presenting themselves to the GP. If we look at hard-to-reach groups, and by the terminology hard-to-reach groups, we tend to think the hard-to-reach groups to include Caucasian men as well. We know that hard-to-reach groups tend not to access diagnostic points in the early part of the pathway, by that the GP. They tend to be diagnosed much later, often through secondary care, and usually through accident and emergency. So really what we're trying to do with this group is actually bring them into the community, get them diagnosed much earlier on. Now, the roots of this project, the DNA, as with most projects, started in policy. And I'm going to refer you to the Cancer Reform Strategy 2007, and Sir Mike Richards, almost slipped up there, will be known to a number of you. One of the chapters, in fact, Chapter 7, Delivering Care in an Appropriate Setting, talked about the idea of looking at healthcare and whether we could move away from providers as a main focus of care towards other streams, other innovative approaches. He talks about healthcare communities, talks about ambulatory care, and the idea of actually using the diagnostic part of primary care as an interface with patients in a much closer, much more bespoke way. So for the first time, community-based prostate health clinics were mentioned. What he thought there was to create an infrastructure, create an environment where men without symptoms could come along, have a PSA test or the equivalent. If they had symptoms, they could talk it through with a healthcare advisor. If necessary, have a biopsy. And that there are other disease conditions that could also be treated as well. Now, we talk about decision advisors. These would be people that people could drop in and see and have a conversation with. And at the time, very much the decision advisor was felt that it could be a clinical nurse specialist or advanced nurse practitioner. So there's something about the idea of this being perfect for nurse-led clinics, nurse-led models, which currently exist in the National Health Service. From the policy, the blueprint, the Prostate Cancer Advisory Group, which is a national steering group of clinicians, researchers, service users, and patients, started to put some flesh on the bones of the policy. How would this pilot look like? How would it run? And what they felt was it was really important it should be based in the community. It shouldn't be secondary care based. They felt it should offer open access. Men should be able to self-refer. They shouldn't need the GP to refer them. That was the whole point. Men could walk in. A little bit similar to perhaps STD clinics. The hours should not be Euro-specific. They should not be 9 to 5, Monday to Friday. In fact, they should work outside of those hours because we know that BME groups, hard-to-reach groups, tend to prefer flexible opening. If possible, it should be a nurse-led model with backup support from our consultant, our doctor colleagues. Where possible, we should be able to offer PSA point-of-care testing, but also the infrastructure should link in with the larger charities, Macmillan Cancer Support, Prostate Cancer UK, so on and so forth. So I've talked a little bit about why the clinic was really important, why prostate cancer. Drilling the project down a little bit, why Newham? Why not Islington? Why not Westminster? Why not another borough in London? Well, having worked in North East London Cancer Network as the nurse director, I'm very aware that Newham has a unique, specific set of healthcare challenges. We certainly know that in the last census, the population is about 307,000. And there was a really large bump of about 20% between 2000 and 2010. Second largest increase in the country. And from inner London, it's the most populous borough. So there's something to do with the community. We know the life expectancy for men and women in Newham is lower than the English national average. We know it has the second worst one-year survival rate for cancer in England. So a number of things are starting to make themselves apparent. For men, 25% of all deaths are related to cancer. And the things that we're going to, which are very specific to this project, is if we look at poverty and social deprivation, Newham sits within either the second or the third poorest borough. And it depends when I say second or third, depending on which particular reference or research project you want to receive. So second to third in the whole country. And we have one of the most ethnically diverse populations, between 61% and 70% non-white population, incredibly large. The flip side of that, what sounds potentially very depressing, very upsetting news, is that we had a huge number of local champions that really were pushing for this pilot to come to Newham. The largest champion was the project champion, the clinical lead, Dr. Frank Chinawunda. And for those that don't know, Frank is also the chair of Cancer Black Care, very experienced, great, passionate individual, very strong around inequalities and ethnicity in cancer. We had Councillor Winston Vaughan, the chair of Newham's Council Health and Social Care Scrutiny, literally advocating for the pilot to come to Newham for the last 2 to 3 years, very strong advocate. We had the APA, the Association for Prostate Awareness, which was run by Ron Reed. This was a local prostate cancer charity for black men working out across London. They were based in Newham, so they had a really strong calling card. We also had the chair of the PCT closely involved, very strong advocate, a number of GPs with specific interests. Prostate Cancer UK were running a number of national support structures called Older and Wiser projects. These were basically voluntary based. What they would get would be older Caribbean men to work in local communities to raise prostate cancer awareness for their local community. So prostate cancer were already on the ground. And then North East London Cancer Network, of which I'm the nurse director, we've always had a strong interest in ethnicity and cancer. We've done an awful lot of work around prostate, also around breast cancer. So all the players were there. So what happened next? So if we look at the design and developmental phase of the project, in spring 2009, Newham was identified as a pilot site. A steering group was quickly formed and a number of local meetings began to take place, both within North East London Cancer Network and also within the Department of Health. North East London Cancer Network were brought on around the summer and the autumn of 2009, and we were brought on in a consultancy capacity to offer expert support and advice. What we then quickly did was bring in some of the major players that needed to be part of this, Prostate Cancer UK, as well as King's College London, who would be carrying out the evaluation of the project itself. The initial project problem that we had with the project, and one that was to carry on, and again it'll be part of the learning, was that there was no identified project manager. With 7 organisations working closely together, It was a question of some of the organisations taking on project management at one time or another, or offering support. And that was something that unfortunately led to some of the problems with the timing of the project. So there was no project manager per se. We had project management support, but no project manager. And during the time period, the pilot experienced a number of setbacks regarding funding and choice of location. We go through choice of location first. We were in consultation with West Ham Football Club. We thought this would be a great community place to actually have the clinic. A number of men go there. It's well recognised. It's thriving. It's vibrant. So we did a lot of conversations with the West Ham Football Club. Unfortunately, for one reason or another, that didn't take place. And then there was an issue to do with the funding, and the funding was coming in through multiple sources. Obviously, when you run a pilot, you'd like your funding to be through one source, not through 4 or 5. That caused an awful lot of stress to the steering group, and me in particular. And there was one example in early 2010 when we'd agreed the funding from Newham PCT, only to see it frozen by the elections. And star chambers were being set up to suddenly start to recreate funding. So when you run pilots, all of these little things suddenly explode, and you have to deal with them, move around them, and react. So it was a particularly trying time in that year. Having said that, during those 2 years of inception, we didn't waste the time. We set up a number of clinical pathways. We started to look at our workforce structure, who would we need, and we built up our objectives. And you can see the objectives here very clearly. We wanted to provide a service to which men could walk off the street, literally walk into. We thought there would be a one-stop shop. We didn't want people to visit this room for the PSA test, this room for the digital examination, this room for the bladder ultrasound. We wanted to do it all under one roof. We found that worked really well. There was something to do around testing choices, the ability to give men a safe environment to listen to and talk with a healthcare advisor around PSA testing. What are the implications? We didn't want to create an environment where men came directly to us and just said, I want the prostate-specific antigen test. We wanted to give them time to reflect, look at the implications. And on top of that, we really wanted to get a really good qualitative feel of what it was like using the clinic, not only for the clients, but also for the healthcare professionals that were working in the clinic. So, hurrah, summer 2010, we identify a location where we're going to set up. This is fantastic news, and the steering group are thrilled. It was a place that we'd looked at earlier, couldn't really form a strong opinion, and then we did a visit. So it was the African Caribbean Resource Centre in Newham, and this is a fantastic, thriving community location. Very strongly identified with the BME community, both men and women. A number of classes are held there. It's recognised, very well known if you talk to anyone within Newham. We felt the location was perfect, the size was perfect. We could access it for clinic. We had a place to store all our equipment. Then we hit a snag. And I can understand why we hit the snag. Because we were using NHS workers from across the boroughs, NHS Newham wanted to actually come and do a health and safety inspection. We understand that, that makes sense. So they sent in the health and safety team. Basically, the health and safety team said, this is not fit for purpose. We think this is dirty, we think this is unclean, this does not meet NHS standards, and we seriously would ask you to rethink on the location. So there's very strong words coming out. Now, Frank Chinawunda and a number of the steering group immediately leapt to the defence. And really what we were trying to acknowledge to the team at Newham was we were not trying to recreate the NHS in that environment. We did not want to create a middle-class, safe, sterile environment for people with sharp elbows. That was not the point. We wanted to create a clinic that would reach out to those that couldn't reach out for themselves. That was the whole purpose. So there were some strong words, went backwards and forwards with the team. We made a number of adjustments, but we felt that it was really important that we held onto the clinic, so we did. Next flag was we hit a number of timeline delays, which was very unfortunate. We were due to open in September 2010, October 2010, and November 2010. They slipped. They slipped for workforce reasons and also procurement reasons. So you need to be mindful of these. So the next few photographs, while I take a sip of water, because it's actually quite dry up here, will give you a sense of the clinic itself. So as you can see, there's a sort of very much a community building, a school sort of set up. This is actually the main corridor going into the actual where the clinic was set up. This was the main hall that we would use, and we would use screens to segregate and to work with the patients and the healthcare professionals. And one of the feedbacks that we got from some of both the patients and the healthcare was the use of the word pop-up. And in this instance, pop-up was used in quite a critical sense. The actual clinic would be set up and decanted in the same day. It would take 15 to 20 minutes to establish. So that was great. All the equipment was kept in the community hall. But I see pop-up quite positively. I've been to pop-up restaurants, they've been fantastic, and a number of pop-up shops. So I think the word pop-up is completely appropriate, but I think I would use it with a positive spin. This is one of the consultation areas. Our equipment. And for people that don't know, the gentleman on the left is Dr. Frank Chinawunda, Dr. Frank to the community of Newham, as he's known, counselling one of the clients who'd come in. So the operational aspect, we did a soft opening, which a lot of hotels, restaurants do. We opened 1 day a week between 2 and 7:30 on a Monday from December to mid-January. We then increased that to 2 days a week, 2 o'clock until 7:30, and we launched the clinic more formally at Prostate Cancer Awareness Month in March. We offered multi-professional advice and support. We had doctors, clinical nurse specialists, we had healthcare workers there as well. And really the whole purpose was people to drop in, they could self-refer themselves, we didn't need a GP referral, they could come during the time, they didn't need to make an appointment. There was a triaging system that they would have to wait, and that was one of the complaints, but they knew they would always be seen. We saw all of our clients who came in, and they liked the idea they could refer themselves. I'm going to go down and do my shopping, I'll pop into the clinic. Or I'm going to go to the library, I'll pop into the clinic. There was no, you had to keep to an appointment. It was down very much led by the patient, the individual themselves. We offered a host of clinical examinations and diagnostic procedures. We did digital rectal examination, bladder ultrasound, flow rates. We did blood for PSA testing. Originally, we'd hoped to do PSA testing on site, but for a number of reasons that wasn't possible. But PSA, the bloods were then taken through to Newham by the clinical nurse specialist, where the results would go back to Dr. Chinawunda, who would write to the patients. If the patient didn't have a PSA testing, then we would give them an examination front sheet, which they could take to their GP, so the GP knew that they'd been to the clinic. Our communication strategy was a twofold approach with PC UK and Newham as well, and we did a variety of both leaflet drops, posters, newspaper drops, radio interviews, and we even used a bus campaign, which I'll go on to talk about. So this was our leaflet drop, and it came in both poster size. This was a drop-in in the Newham recorder, and this was our bus campaign, and we had posters on the back of buses and also on the inside. We had 2 concentrated bursts of activity, January through to April 2011 and November to December 2011. What was really important and what was great for me to share with you is over half the men came to the clinic because of the advertising they saw. So the advertising worked. Men were coming through because of what they were reading. The other thing that's really important is a quarter of the men, 25%, came because a friend or colleague recommended it. Peer-to-peer referral. Really, really important. If you can start to build up peer-to-peer referral and start to get that momentum going, it's a really great support in this sort of thing. Very quickly, an evaluation on the communication strategies and what works, and what I'd like to show you here, these 2 peaks coincide with drop-ins in the Newham recorder. Newham recorder is a local press. The men read it, they enjoy it. Didn't cost us anything to put the interviews in. The bus campaign, by more example, which was really expensive, about £4,000, shows a decline in attendance. So it was obvious for us that the bus campaign didn't work. Now, that might be something you might want to consider locally. You might want to use local media rather than perhaps buses or tubes. Moving very quickly on to the evaluation. So as I mentioned, the clinic opened twice a week, Monday to Fridays. We ran on 98 consecutive days between 2010 and 2011. 328 men visited the clinic. 322 men had a consultation. Almost 60 men were referred to secondary care. 9 men were diagnosed with prostate cancer, and it's really important to point out 9 men were diagnosed with early stage prostate cancer, not late stage, which we tend to see more through secondary care diagnosis. And really interesting, because we didn't think this, we dropped the ball on this, was we picked up 3 other men with other medical or surgical conditions. We were focusing on prostate, so we just thought around prostate. Actually, men were coming with other conditions to do with the bladder and to do with the stomach. 55% of men who visited the clinic had urinary symptoms. What's really important to note is of those, half had not thought to go and see the GP with the symptoms. They were symptomatic, but they weren't prepared to do anything about it. Some of that was to do with they thought that their symptoms didn't warrant going to the GP, But we also know that some of them didn't visit the GP for a number of reasons. The triaging of GPs, the fact that they felt the GP didn't take them seriously, the fact that they got limited availability with their GP. An unintended consequence of when we ran the clinic was GPs started to refer in, only very small, 3%, but that wasn't why we set the clinic up. We didn't set the clinic up to make it easier for GPs, but GPs were starting to actually refer in, which was a strange side effect, so we had to deal with that. Vast majority of people who visit the clinic did have a PSA test. Nearly 3/4 had a digital rectal examination, 56% for flow rate, and 52% for blood or ultrasound. There are a number of diagnostic procedures being carried out. Just very important to point out in terms of the demographics that 46% of men who visited the clinic call themselves Black African or Black Caribbean versus 28% of Caucasians. And the next important point, 3/4 of the men who attended the clinic were living in areas classified within the 5th quintile, the most deprived area. We were picking up the poorest populations, which is what we intended to do. In terms of patient experience, Monday or Tuesdays, both days were equally given a good review by the patients. There wasn't one day that was better than the others. Of interest to us, when we thought we'd see a peak in the evening, the men who were coming tended to prefer the 2 to 5 slot. Although, as I show there were a number of men of working age under 65 who did prefer to visit after 5 p.m., 71 men. A quarter attended through word of mouth, as we mentioned. 83% of men who visited were very satisfied, and 100% of men would refer the clinic to other colleagues, so extremely important. Just to be aware very quickly, we had 22 men who lived more than 10 kilometres away, so people were prepared to travel. Economic modelling, the cost of the man per visit was £282. However, this was a pilot, so we were starting to learn about it. What we quickly then worked out was if we did some workforce redesign, looked at procurement costs, we could drop that to 182. If we really targeted and got more men to visit, so say 6 men per clinic, that would drop even further. And we haven't even factored in cost savings associated with the early diagnosis of prostate cancer or the other medical conditions. So in conclusion, we think symptomatic men attended the clinic who may not have gone to their GP for advice, so we think there is a role for this sort of community infrastructure. Men were diagnosed with other conditions, ulcerative colitis, benign hydroplasia, which we think could actually travel into a well men clinic. Scored very highly in terms of patient experience. People were prepared to travel more than 22 kilometres to visit. Local advertising worked. And we showed that a large multi-agency collaboration can actually work. I'm not going to talk about this because I am conscious of time, and David's sitting there, he's given me the nod. But what I would like to say is if we're moving forward with this, I would suggest very, very strongly you have your funding sources identified, you have a project manager assigned. Now, people will nod and say, well, that's obvious, of course, but I've worked on a number of projects where project management is given to another person as part of the steering group. You don't actually appoint a project manager. You really do need to have a project manager. Working very closely with academic partners and charities very early on in the project was a great benefit. It allowed for some different thoughts, from different approaches, some different innovations. So I would really have them on board when you put on your steering group. One point to take away, because of the size of the agencies involved, the project succeeded on the currency of goodwill. This was a labour of love, and it worked because everyone in the steering group was committed to making it happen. In longevity, if the pilot carries on, I couldn't guarantee that that would take place, so you need to look at how you would then take that forward and replicate. I think I'm going to stop there. That's my email details if people want to email me to learn more about the clinic. King's College have done a really fantastic evaluation of the project. Jenny Jones, if you email Jenny Jones, she'll make sure that you get a copy of the evaluation. Thank you very much for listening.
Well, I think obviously the future of the work is we'd like to see the clinic duplicated anywhere elsewhere. We've proved two things, we think, quite powerfully. One is that men from BME communities will visit a bespoke prostate health clinic where there's accessibility, flexibility, individuality. And two, that because we picked up a number of other conditions, non-benign conditions such as ulcerative colitis, we think there are legs, or rather there's the opportunity for a well-manned clinic of sorts that's based in the community, specifically aimed at hard-to-reach men.